So next is BRCA, or family history of breast cancer. How do we assess breast cancer risk associated with the family history? An initial assessment is made in primary care according to the NICE guidelines and followed by referral to secondary or tertiary unit. Overall, 4 to 5% of breast cancers are currently thought to have a genetic cause. In women under 30 years old, this rise to approximately 25%. And discuss the patient and family history, MDT, refer to genetist to confirm the detail and degree of the risk, calculate the likelihood of genetic defect or risk above the average. Broadly, how would you classify the groups of risk levels? So population risk is 17%, lifetime risk less than a 10-year risk is 3%, managed in primary care. Moderate risk, lifetime risk of 17 to 30% risk, and 10-year risk is 3 to 8%, age 40 to 49, managed in secondary care. High risk, lifetime risk of more than 30%, and 10-year risk is more than 8%, and more than 20% chance of fully BRCA1, BRCA2 or TP53 gene, managed in tertiary care. What are the cancer risk associated with the BRCA1, BRCA2 gene? BRCA1 breast cancer, lifetime risk 60 to 80%. Ovarian cancer, male cancer, prostate cancer, pancreatic cancer, and BRCA2 breast cancer, ovarian cancer, male breast cancer, prostate, pancreatic cancer. What are the pathological characteristics of BRCA breast cancer? Again, we don't need to go into BRCA1, BRCA2. What are the NICE guidelines for screening patients with gene defect in family history? So again, BRCA1, BRCA2, TP53, high risk family members, and they need MRI. What are the benefits of screening these women? Identifying cancer at an early stage, not reducing morbidity associated with the breast cancer treatment, no mortality benefit. And how else can these patients manage? Chemoprevention by tamoxifen, raloxifene, risk of endometrial cancer, DVT-PE, and risk reduction surgery for breast cancer plus minus breast reconstruction, discuss as risk reduction MDT. And then is the risk reduction for ovarian cancer, and give lifestyle advice. How would you approach a patient with a known breast cancer who is a BRCA1 carrier? Index cancer is the primary concern. Mortality is linked to the index cancer rather than possible future risk. Physical breast surgical and oncological treatment of the index cancer. Risk reducing surgery may be offered contemporary, however, bear in mind the risk of delay to adjuvant treatment if complications rise. Do you know any other genetic mutation associated with the increased risk of breast cancer? Li-Fraumeni syndrome, it's TP53. And wide range of tumors, soft tissue sarcoma, osteosarcoma, breast cancer, brain, CNS, adenocortical, leukemia, lung, GI, kidney, thyroid. Cowden syndrome due to mutation P10, lifetime risk of breast cancer 85%, and hereditary diffuse gastric cancer, Peutz-Jeghers cancer, and Lynch syndrome because of MH6, PMS2, and PLAB2. How does the outcome of family history analysis affect the patient? If family history suggests genetic defect, there is a need to discuss genetic testing and implications. Ask the patient how would deal with the result confirming mutation. Ask about the effect on job, family, and children. The patient should consider financial implication, insurance, and mortgage. What are the problems with screening these patients? Screening does not prevent breast cancer. Anxiety occurs especially after recall for indeterminate lesions. Do you know if any family history studies? Again, FH01 study, risk trial. And thank you.